learning techniques for medical imaging application. We are delighted to have with us a resource person, Dr. Neha Watts. Dr. Neha is a postdoctoral researcher at the Central Institute of Mental Health in Mannheim, Germany. She earned her PhD in Diagnostic and Interventional Radiology from Heidelberg University, Germany. Her work has been published in numerous peer-reviewed journals and presented at international conferences. Her research focuses on medical imaging, particularly MRI, MRS and CT, quantitative image analysis, neuroimaging, and the integration of machine learning techniques in healthcare. We are truly fortunate to have her here to share her expertise and experience with us. With great pleasure, let's welcome Dr. Neha Watts to begin today's session. Welcome, ma'am.
Yeah, thank you so much for such a nice introduction, and thank you so much for inviting me here. So, as you already mentioned, my topic for today will be CT and MR quantitative imaging and its clinical applications. Quantitative imaging in itself is a very huge topic, so I hope that by the end of this talk, I will be able to pass some of my knowledge or basic insights about quantitative imaging to all of you, so you all have a basic idea about quantitative imaging. Let me start with giving you a simple analogy. Imagine you are watching a car pass by, and you could either say that the car is going very fast by simply looking at it. Or now imagine that you have a speedometer or a radiometer, then you can measure the speed of the car, and you can say that the car is going at a speed of 90 kilometers, 80 kilometers, or you can quantitatively tell the speed of the car. Now the situation comes that you have to issue a speed ticket. Which information will be helpful for you to make a decision in issuing a speed ticket? Whether saying that car is fast or having a quantitative value of speed with which the car was going. Obviously, in my opinion, it will be the second one, that is quantitative data. So we prefer quantitative over qualitative, right? Now moving on to scientific terms, why qualitative versus quantitative imaging? Similarly, in the medical images, traditionally, radiologists used to assess the data qualitatively. That means that the radiologist looks at an image and makes a judgment based on the experience that this tissue looks denser or that lesion looks suspicious. But this is very subjective approach. Two doctors might have slightly different opinions. Quantitative imaging, on the other hand, turns that images into numbers. That is, it reduces the subjectivity. It enables computerized segmentation and AI applications in medical imaging. These numbers could be tissue density, this could be tumor volume, tumor size, or signal intensity, and various other features that we will discuss later in this talk. So this makes diagnosis more objective and reproducible, enabling better clinical decisions. So quantification of medical images has the potential to detect early disease, complement biopsies, and provide clear differentiation of disease stages. Their evolution of quantitative imaging, so in 1970s to 1980s, earlier CT and MRI primarily was used for qualitative diagnosis. Quantitative imaging came into picture from 1990s, but that was some conventional quantitative measures such as Hounsfield units in CT, T1, T2 relaxation mapping in MRI. From 2010, a rise was seen in the quantitative biomarkers with some advanced imaging techniques such as diffusion-weighted diffusion tensor imaging, perfusion, spectroscopy, and various others. We will discuss some of them in the basics about them so that our audience is more computer oriented. So I hope that you will be able to get at least some knowledge about it. In 2020s, now we are focusing more on integration of these radiomics, AI, and multi-center standardization driving clinical and research applications. So first, what is quantitative imaging? According to Quantitative Imaging Biomarker Alliance from RSNA Society, quantitative imaging is the extraction of quantifiable features from medical images for the assessment of normal or the severity or degree of disease. In simple terms, you extract some quantifiable features which helps you distinguish that this tumor or this tissue is healthy or this is a diseased tissue. So quantitative imaging is not simply just a digital image of zeros and ones. It is a complete process of imaging. Here, first you acquire the image at the scanner. That could be a CT scan, MRI scan, or anything. Then an image pre-processing is performed, followed by image registration and image segmentation. So you segment a particular area of the image. That could be any tumor or any cancer or any tissue in that organ of the body. And that then you quantify certain parameters from those areas. Those are the quantitative feature, that is the quantitative feature extraction. And these features will then be fed to an AI algorithm or a machine learning algorithm or anything for further computation or analysis or diagnosis in deep learning, in statistics, or anything like that. Then comes quantitative imaging biomarkers. First, what are the biomarkers? Biomarkers are any measurable objective characteristics that are used to assess normal biologic or pathogenic processes. But quantitative imaging biomarkers are objectively measured characteristics that are derived from in vivo images as indicators of normal biological processes, pathologic processes, or response to a therapeutic intervention. They are used for patient risk stratification and treatment response or drug development. Unlike biopsies, in the biopsy, you have to dig inside the tissue, but they can cover wider tissue areas without injecting anything in the tissue, and they allow for repetitive sampling. For an imaging biomarker to be a valuable biomarker, it should have some key characteristics, such as reliability. That is the degree to which a measurement is accurate. The ratio of results variance between subject measures of total variance based on the observed measurement. Reproducibility, that it should be able, you should be able to repeat the measurement and get the similar results. Measurement precision under a set of repeated conditions. Sensitivity. A biomarker should be sensitive to pathophysiological conditions that we want to image and the range of parameter change anticipated from the therapy. So if any imaging biomarker fulfills this criteria, then only it can be considered as a valuable imaging biomarker for quantitative imaging. There are various quantitative imaging approaches. We will for now focus on 3 images. First is PET, positron emission tomography, as that is not my area, so I'll just give a brief about it, that it quantifies distribution of radioactive tracers in the body, and standardized uptake values of these PET correlates with the treatment outcome. Second one is computed tomography, that is CT. Here you can calculate direct quantitative parameter maps. You can calculate tumor size, tumor volume measurements, or perfusion imaging for assessing blood flow, blood volume, and certain other parameters. Another one is MRI, that is magnetic resonance imaging. Multiple images with model fitting. You can infiltrate the tumor margin. You can calculate functional imaging for metabolic and diffusion processes. So we will only focus on CT and MRI in this talk. Let us start with CT quantitative imaging. So in CT quantitative imaging, it can provide us with a wide range of quantitative imaging tools, such as 2D measurements, two-dimensional measure. Sorry, is there anyone? I can hear someone.
No, continue. Continuously.
Okay. So it can be a two-dimensional from a conventional CT, which are used to assess tumors or diseases, or it could be attenuation Hounsfield units in case of CT that is used for electron density mapping. Or you can measure whole volume of the tumor, that is the volumetric analysis. Then comes some advanced CT imaging techniques, such as multi-energy CT, where you can measure the iodine concentration in that particular region, Or there is a dynamic contrast enhanced CT for perfusion and capillary permeability measurements. There are more standards such as image processing or statistical methods nowadays, such as radiomics and texture analysis that are used in CT to diagnose other various diseases or to help in treatment or therapeutic responses. Then all these parameters gives us either anatomical information, functional information, or molecular information about the area being imaged or scanned. I will not discuss this more in CT as I'm anyway gonna discuss this in the MRI, the texture analysis and everything. So we will see that in the next slides. So in CT quantitative imaging, I'll just show you some images that how does those parameters looks like. There are few examples such as tumor density. So by looking at these images, you can quantify the tumor density in Hounsfield units. To measure the tumor size, you need to delineate the tumor area and then you can calculate the tumor size in mm cube. You can also compute blood flow measurements, blood flow maps as seen in that ROI. You can see a blood flow region on a CT perfusion image. You can also calculate iodine maps as I mentioned with the help of dual energy CT. And I want to show you how a dynamic contrast enhanced CT looks. So in dynamic contrast enhanced CT, first we acquire a baseline CT image where no contrast agent or no injection is given to the patient. And then dynamically after injection of contrast agent, we acquire the CT images. So this is how all these dynamic CT images looks like. This is a series of 34 dynamic images. Using these images, you can calculate different parameters. For example, volume of extracellular, extravascular space or blood flow or blood volume information can be calculated with the help of these images. So clinical applications of CT quantitative imaging, it has various clinical applications almost in all over our body. I'll start with pulmonary. In pulmonary lungs, it helps in nodule volumetric for lung cancer screening. Main application is chronic obstructive pulmonary disease, COPD, or in case of emphysema. It also helps in interstitial lung disease diagnosis. Then in pancreas, so a lot of people die due to pancreas because it is not very easily diagnosed at an early stage. It takes higher stage to diagnose a pancreatic cancer. It also helps in pancreatitis and pancreatic necrosis. In genitourinary, for example, to diagnose stone burden, tumor burden, or cortical volume. In the cardiovascular applications, for coronary artery calcium scoring, for plaque quantification, and for cardiac function, CT quantitative imaging can be used. In hepatic, liver, so to measure fat, to measure iron inside the liver, for tumor burden, for lobular volume, we can use CT quantitative images. In the musculoskeletal applications, it helps us to measure bone mineral density or fat, visceral fat or subcutaneous fat. In case of fracture prediction or muscle volume can also be measured. Then also in the cases of bowel or intestine to diagnose polyps. There are certain challenges associated with CT, as everyone around us might know that CT is associated with high radiation dose, and there are lack of standardized protocols for standard CT quantitative imaging. However, dose can be reduced by various parameters by reducing tube voltage, by reducing temporal sampling. These are the certain parameters associated with CT. So, but I'll just give you an overview, or by using certain methods or changing certain parameters of the CT, you can reduce the radiation dose. And we worked on one area, so it's a new technique. It has not been worked in abdomen before. So we implemented a first pass analysis technique as an alternative to CT perfusion, which reduced our dose to almost 90%. So this was this is the study published where we introduced this first pass analysis technique for reducing the dose in CT perfusion in case of pancreatic cancer. So if anyone is interested, you can, I don't want to go in detail about this. Now I'll move to MRI quantitative imaging. MRI-based quantitative techniques. First is MRI relaxometry, that is structural imaging. So if you look at the conventional structural MR images, you can quantify spin relaxation time constants. For example, T1, T2, there are certain relaxation times associated with MR imaging, which depend on the biophysical tissue properties. You can calculate T2 star, that is also a parameter that has been associated with tumor hypoxia. There are another MR imaging technique, that is diffusion weighted MRI, which measures random motion of water molecules in the tissue, quantified as an apparent diffusion coefficient, ADC, a parameter. So low ADC indicates high cell density, or it indicates that there is a tumor, while high ADC suggests a necrotic tissue. So with the help of DWI ADC maps, we can differentiate between tumor regions, necrosis, or normal tissue. We will discuss this more in detail. Then another MRI quantitative technique is a DCE MRI, that is dynamic contrast enhanced MRI. Studies contrast agent distribution to quantify tissue and perfusion and capillary permeability inside the tissue region or the tumor region. It can indirectly assess parameters related to tumor hypoxia. So all these are the MRI-based quantitative techniques that you can use separately, or you can combine them to diagnose a particular disease or for any treatment response. First, quantitative MRI structural imaging. So absolute quantification of longitudinal relaxation time T1. If you have a basic idea about MRI, I hope that you will be able to understand a little about relaxation times. So it's absolute relaxation of longitudinal relaxation time, transverse relaxation time T2, and proton density PD. It provides an objective evaluation of development, aging, and diseases. Here is an example of how a T1 weighted image, a T2 weighted image, and a PD image looks like. Here you can clearly see in T2 weighted image the white region. So that is a brain tumor region. And you can clearly see some part of it in the PD image also, and very minorly it can also be seen in the T1 image. T1 weighted image. So with these structural imaging, you can only see you can only get the anatomical information. But you can also quantify T1 relaxation time, T2 relaxation time, and proton density from these images. There are certain challenges associated with quantification. First is variability in user-defined settings. Example, different flip angles used or magnetic field homogeneity. Lack of fixed meaning for pixel intensities. But there are solutions. Intensity harmonization techniques can be used to maintain similar intensity. Example, Z-score normalization or histogram matching can be performed, or standardized methods for consistent image analysis can be implemented. Clinical applications of the structural quantitative MRI imaging is, it enables characterization of edema, myelin, or pathological tissue changes. Now we are moving to next, that is diffusion weighted image. Diffusion weighted image, as the name suggests diffusion, it measures diffusion of water molecules to assess the tissue microstructure. As I already mentioned, apparent diffusion coefficient, ADC, is a parameter calculated from diffusion images. It reflects a complex tissue environment that restricts free diffusion of water. ADC correlates with tumor cell density and aggressiveness. Here I show you an example of a DWI image. First one is a normal DWI image at B0, and then DWI image at B1000, and then we compute a ADC map, that is apparent diffusion coefficient, and here also you can clearly see a tumor region nicely visible on a ADC map. So this is used to this ADC map is used to for tumor cell density and to know the aggressiveness of the tumor. Advanced diffusion imaging techniques are used nowadays. So first one is functional diffusion maps, which examines voxel-wise changes in ADC over time. It is an diffusion imaging technique, but advanced version of it. So it provides spatial localization of changing cell density and detecting infiltrating tumor, not visible with the standard MRI. Another one is intravoxel incoherent motion, IVIM. It exploits various influence of microcapillary perfusion and tissue diffusion by collecting DWI. The DWI I showed you in the previous slide only used two B values. One is just 0, that is not a B value, but only one, that is B1000. But here we use multiple V values, and it provides measures of true diffusion and perfusion fraction. And diffusion tensor imaging, which captures directional diffusion information by collecting data from multiple directions, and it enables creation of fractional anisotropy maps and fiber tracking. All these are the advanced diffusion imaging techniques. They have various applications in different disease diagnosis or treatment responses. Overall, the clinical applications of diffusion imaging lies mostly in brain tumors, as ADC map inversely correlates with glioma grade. If a low-grade tumor has a higher ADC, and a high-grade tumor will have a lower ADC. A prostate cancer, where ADC correlates with Gleason score. In case of a breast cancer, where ADC shows cellularity and histological type of the breast cancer. Now, the third type of quantitative MRI imaging is perfusion imaging. First, we start with dynamic contrast enhanced MRI. That is one type of perfusion imaging. It exploits T1 effects of a gadolinium-based contrast agent. So, as I showed you an example in CT, there also we were injecting a contrast agent. So, with dynamic contrast enhanced also, we inject a gadolinium-based contrast agent that extravascate into the tissue, causes increased signal intensity on T1 weighted image. These are used primarily outside the brain, where contrast agent readily leaves the blood vessels. Another, I will show you, this is just an explanation how the T1 effect occurs in a DCE image. So here you can see a T1 contrast imaging, and a yellow arrow shows a tumor. You can see some of the GBCA, that is gadolinium-based contrast agent, moves out of the tissue along with water. So DC image exploits the T1 effect of these contrast agents that move out of the tissue. In the dynamic contrast enhanced MRI, we have semi-quantitative analysis or quantitative analysis. With semi-quantitative analysis, how can we use these DC images? We can calculate maximum enhancement. We can calculate the wash-in and wash-out rate of the contrast agent. We can also calculate the area under the curve of the flow of the contrast agent from entering the tissue to excreting out of the body. Particularly, they are used for breast cancer, where enhancement patterns correlates with malignancy. We can also do complete quantitative analysis, where we can measure certain parameters with the help of some mathematical modeling techniques. So we have this dynamic contrast images, and we use some mathematical models to compute those parameters. Some parameters are K-trans, that is volume transfer constant of the contrast agent. KEP, rate constant between extracellular extravascular space and plasma, how the contrast, the transfer rate of the contrast. Volume of contrast in the extracellular space, VE, or volume of plasma, VP. K-trans parameter has shown promises of predicting response to anti-angiogenic agents and treatment response in various cancers. We will also see these K-trans maps later in my slides. So maybe you will have a better idea how these parameter looks like. Yeah, I've put one example of this K to give you an example. This is the K-trans map of the brain tumor. Now, second perfusion imaging is a dynamic susceptibility contrast MRI, DSC MRI. It explores the T2 and T2 star effects. That is when the contrast agent, you can see these bigger circle, the contrast agent, they are confined to the blood vessels. That creates a magnetic susceptibility gradient that decreases the signal intensity in the T2 star weighted image. So you can see with the yellow arrow, the tumor which was bright in this case in the T1 effect is now looking darker in the T2 effect. It is used primarily for brain perfusion where the blood-brain barrier keeps contrast agent within the vessels. So dynamic susceptibility contrast MRI, here I just give you a overview of how it works. So on the left side, it shows all the dynamic susceptibility images. With the help of these curves, gadolinium contrast agent bolus curves, we can calculate some parameters. The parameters calculated are relative cerebral blood volume, relative cerebral blood flow, or a mean transit time taken by the contrast agent. These are the key matrices that are calculated with the help of DSC MRI. But here also it is associated with certain challenges such as contrast agent extravasation in tumors and need for the leakage correction methods in DSC MRI, and it needs standardization across patients and time. So quantitative MRI perfusion has certain clinical applications. In brain tumors, relative CBV predicts tumor grade, survival, and treatment response. In breast cancer, where K-trans parameter distinguishes benign from malignant lesions. In prostate cancer, where perfusion matrices monitor the treatment response. It assesses the tumor angiogenesis, it monitors treatment and differentiates necrosis. So quantitative perfusion imaging also has various clinical applications in our body. There are certain imaging techniques, advanced imaging techniques also to quantify these medical images, such as fractional tumor burden. FTB is one of the newest developments in quantitative DSC MRI. It enables distinction of high-grade brain tumor from treatment effect on a voxel-wise basis. Its key benefits are that it uses the same RCBV maps to determine whether voxels within the enhancing lesion are tumor or it is a treatment effect. Based on tissue-validated RCBV thresholds, FTB greater than 75% predicts worse survival in patients related to chemotherapy or a drug treatment. It helps inform clinical decision-making. So for a basic idea, I showed a FTB maps that shows tumor region in red on the left side image versus the treatment effect where you can see a white region that is only a treatment effect, that is not a tumor. Then comes another parameter or another technique to quantify these some parameters is radiomics, mining imaging data. So radiomics involves high throughput extraction of quantitative imaging matrices. These are called radiomic features from the medical images for prediction of diagnosis, prognosis, and gene expression. Radiomic features may include shape features that describe geometric properties of the region of interest. Then they could be first order features that are based on histogram analysis such as mean, maxima, minima, entropy, etc. High order features texture features that are related to spatial patterns of the voxel intensities. A lack of reproducibility in radiomic features limits its clinical application. But this is also a field which is under progress, and maybe we would be able to overcome this limitation. These radiomic features, they are also very sensitive to image acquisition parameters, reconstruction algorithms, pre-processing and extraction methods. So hopefully we will be able to overcome that as well. Quantitative MRI acquisition and its workflow. So as I said, it's not just a single image acquisition, it is a whole process. So first, to acquire this multi-parametric MRI images with standardized protocols and sequences. These images were then pre-processed using image registration, noise reduction, motion correction, and etc. using various approaches, various techniques. With the help of some mathematical models, we extract quantitative MRI parameters. Then the post-processing is done that involves ROI definition, smoothing, artifact correction of the ROI regions. There are certain challenges associated with this that include partial volume effect or signal to noise ratio is low and fitting uncertainties in these quantitative MRIs. Then DICOM standard and validated pipelines ensure data management and transparency. So this quantitative image acquisition is a complete workflow. As I mentioned earlier, that you do not have to acquire just one of these quantitative imaging technique. You can acquire a combination of them that can help based on your requirement, based on your disease diagnosis or treatment or application. So combining multiple imaging matrices for enhanced diagnostic accuracy. Integration of multiple QIBs, that is quantitative imaging biomarker, enables better tumor grade and prognosis discrimination. Multiparametric and composite biomarkers, they support adaptive or individualized treatment strategies. They have various applications when you combine these parameters in tumor grading, in treatment response prediction, or microstructural analysis. But there are also certain challenges associated with it as time constraint, because to acquire these many multiparametric approaches, it is a time consuming process. Also, it is associated with false positive results. We have image misregistration problem because we have to register the image, all of these different images. We have one of our study published using multiparametric imaging that helped us differentiate two brain tumor types under using a machine learning framework. So we quantified multiparametric parameters and they were fed as a feature set to a machine learning framework that helps us differentiate between two tumor types that were difficult to be separated based on the conventional images, or that was difficult to separate by just looking at those images. As I mentioned, it's a huge topic, so I am not going in a detail of all the tumors, what parameters. I just want to you have a basic idea. So I will show you how these tumors and what tumor we differentiated. On the left side, you can see a pilocytic astrocytoma. That is our one tumor type, and glioblastoma was our another tumor type. So if you look at the first row, in the first row, you see all these tumors. So the first one is T2 weighted image. Second is also a MR sequence FLAIR image. Then we have T1 weighted post contrast. From slope 2 to ADC map, you see certain parameters, certain images, certain quantitative maps that we quantified using these multiparametric images. And here you can clearly see in the difference between the first row tumors and the second row tumors. which was not visible in first 3 columns. But from column 4 to column 6, 4 to 8, you can clearly see that there is a difference between these two tumors. So that's how in this study, we find out that combining these parameters or combining these imaging techniques, for example, perfusion and diffusion, helped us differentiate the tumor types, which was difficult for the radiologist before. Now, the main challenge comes is that the standardization of quantitative imaging, because we do not have any standardized quantitative imaging protocols that, okay, this is the protocol, this is what we follow, and we will have a standard certain images. And if we go from one scanner to another scanner, we go from one center to another center, or at any different time, then it is not reproducible, or if it is not reliable. So we need standardization techniques that ensure the reliability and reproducibility across devices, across centers, and over time. It minimizes the variability in imaging results as well. What are the possible efforts that we can make for standardization of these quantitative imaging techniques? We can use imaging phantoms for calibration. We can use digital reference objects for software validation. We can have CUBA profiles for CT MRI that are standard profiles used, universally used. We can have multi-center studies for reproducibility, and data harmonization techniques such as scanner-specific corrections could be done to achieve this standardization, standardized technique for these quantitative imaging. In this area also, we have tried some techniques to standardize CT quantitative imaging techniques because that was comparatively simpler than MRI. I cannot show you any results or anything. That study is still under review, but we are already working on some of the areas to standardize these techniques, and we have got somewhat good results. So there are other studies also that are working. So hopefully we would be able to standardize these techniques. Now coming to AI and machine learning in quantitative imaging. So first, AI applications in medical imaging. It can, in quantitative medical imaging basically. So it can help in lesion detection, segmentation, and lesion classification. Deep learning techniques can improve the problems with image reconstruction, or it can also help in reduction of noise. So we get better images with less noise that will ultimately help us in better diagnosis of the disease or better treatment response. What are the benefits for these biomarkers? So AI can help automate these biomarker extractions. So it will help reduce the variability, and it will also improve repeatability of these biomarkers. Challenges that we face when we use AI in this area is that the scanner variability, because GE, Siemens, or everyone has their own protocols, and even if you use GE, one of the vendors, and you go to different centers, then also there is a variability introduced. Training with a heterogeneous data set. So the data set that you will be training will be very heterogeneous. It will be, if you implement one AI model at one center, you cannot make sure that that will work similarly at another center or with another scanner or with another vendor. Quality assessment of these AI algorithms is also a critical challenge. Developmental guidelines. So we can have development guidelines, like we can have validated data set, we can have external testing, and we should have quality control. So to develop a robust AI algorithm in this area, training dataset should use heterogeneous dataset that account for variability in acquisition parameters, machine settings, and clinical conditions. And also in quantitative imaging cases, we cannot only look at the data after acquisition, we also have to look at the metadata, because the metadata has all the information about the parameters involved, about the scanner and everything. That also needs to be incorporated while using any AI or a machine learning algorithm in these data sets. Challenges in quantitative imaging. First, some technical hurdles that we face. So variability across vendors, as I have been saying this for, I have said this so many times, and imaging protocols. Patient positioning, differences between diagnostic and radiotherapy. Problems that we face with data processing. This I will also show in little more detail, but with pre-processing in image registration, in parameter estimation, voxel-wise or ROI-wise, post-processing and data reviewing. Standardization, so there are need for quality assessment routines, phantom measurements, and adoption of radiology guidelines for radiotherapy. There are certain barriers, variability in imaging devices and biological differences among the patients, and there are reluctance in clinical adoption due to complexity of these techniques. Field strength is a problem. B1, B0 field inhomogeneity is a problem, and temperature control is also a big barrier. So the data processing challenges that we see, first in the pre-processing stage. So converting this raw data into a format for model fitting, and that includes image registration, resampling, or denoising, is already a very tough task, followed by parameter estimation, where you have to have a mathematical model, pre-process the data to extract the quantitative parameters. That could be either voxel-wise, that preserves spatial information, or ROI-wise, which increases the signal-to-noise ratio. So you have to decide. We also face challenges at the post-processing state, where further noise reduction, smoothing, or ROI definition are challenges that are to be taken care for analysis. Now, what are the benefits of these quantitative imaging so far? So in the clinical impact, first in the clinical, it adds precise information on the disease characteristics. By quantifying these with quantified parameters, it creates storable, searchable database of quantitative results that you can use for further analysis. It helps resolve differences in image interpretation because you have a quantifiable value. It adds biomarker results to the patient management. In research, it demonstrates treatment safety and efficiency with higher precision has been achieved. Quantitative imaging reduces statistical noise in biomarker measurements. It can reduce required subject numbers, and it can reduce time and cost of treatment approval processes. So, by reducing variation in the image biomarker measurement process, quantitative imaging can significantly improve both patient care and clinical research as well. What are our future directions? So there are certain imaging trends that we see in the future. Integration of AI and deep learning for advanced imaging analysis. Wider adoption of radiomics in the clinical trials. Improved reproducibility and validation methods. And standardization of imaging modalities for universal standards or universal acceptance. Our research focus is on large multi-center studies should be on large multi-center studies to validate these quantitative imaging biomarkers and development of radiotherapy specific imaging solutions. Example, dedicated MRI coils for radiotherapy purposes. In the clinical area, future directions shows us improved tumor visibility for contouring of the tumor, personalized radiation dose based on tumor heterogeneity, and enhanced treatment efficiency with reduced side effects. So these are all the future areas of quantitative imaging that we see in the near future. In the conclusion, I would like to say that quantitative imaging in CT and MRI is transforming clinical practices and research, and adherence to standardized imaging protocols is a critical step for reliable and reproducible results. Future advancements will further integrate quantitative imaging into routine clinical workflows. That so many radiologists were reluctant at the beginning, but nowadays I see many radiologists focusing on that. Or also recently I was at an event with Siemens, and their radiologists were urging or asking Siemens to introduce these quantitative imaging parameters inside the software tool, so they can just with one click and go, they can also get these quantitative maps. That shows that they also see these quantitative imaging maps being helpful in their tumor diagnosis and in their treatment. So what are the key takeaways? That quantitative imaging enhances diagnostic accuracy and reduces subjectivity. These are the points that you can keep in mind, even if you, whatever basic introduction I gave in this talk maybe. That quantitative imaging enhances the diagnostic accuracy and it reduces subjectivity. MRI and CT offers unparalleled potential for tissue characterization and treatment monitoring, and we see that on everyday basis. Quantitative imaging holds great promise for radiotherapy. Overcoming the technical and standardization challenges associated with quantitative imaging is critical for clinical adoption. And introduction of radiomics, AI, deep learning, they are transforming imaging analysis. In my opinion, it will take time. It will take a lot of time because there's a huge gap that we see between using AI techniques in research or in one of your model and bringing it to a clinical practice or bringing it to a real world scenario. We still do see a huge gap in that. So I'd like to thank you all for your attention, for inviting me, for having this talk. And I would like to thank both my groups, my master's group, where I learned all the basics and everything, every knowledge that I have now, my master's group and my PhD group in India and in Germany both. So thank you so much.
Thank you, ma'am.
This is the time for question and answer. Any participants, if you have any questions or queries, or we will open for discussions now. So anyone please put your questions in the chat box, or you can unmute and ask. Think no question, but Neha, during your session, I have a small doubt. Like your suggestion is like AI implement with another scanner or another vendor. It's not similar. And if AI comes into the picture now, I think in last 10 years, so still they means the researchers are struggling with this that variability problem, or what is your experience that inter variability or inter scanner variability or vendor variability? Can you expand a little bit more?
Yes, they are, because okay, so for this I did one meta-analysis, and I during the meta-analysis I computed all the CT perfusion pancreatic tumor studies, and there I see that how variable the data could be. In fact, how variable the quantitative imaging parameters could also be. For example, if you look at blood flow maps, only, and changing certain, even a single parameter or maybe some of the parameters had influence on the blood flow maps or on blood volume parameters and other quantitative imaging parameters. And when we look into this AI, we only there are models that so far I see we only consider these quantitative parameters, blood flow, blood volume, texture, and all these as a feature set. And based on that, we do the tumor diagnosis, characterization, or segmentation. But as I noticed, even before acquiring, so acquisition parameters also have influence on these quantitative parameters. So we also need to take care of these acquisition parameters as well. And similarly, the vendors. So if you, because I have looked at data from different vendors or different scanners, and I do see the variability in that. So, and that information we can only find in metadata. So my opinion would be, if we want to look into the parameter, the features for AI, I would also consider looking at metadata.
Okay, that means your point is the AI engineers not only looking, I think most of the engineers are or computer scientists are more focused on the images instead of these, including the metadata. They are avoid mostly the metadata. Yeah, and
Yeah.
they are looking the images and feature selection, feature extraction.
Yeah,
Your
exactly.
point, yeah, your point is
Yeah.
we can include, then it will reduce these kind of like errors or in the reader
Yeah,
variability.
exactly.
Or in,
Yeah.
Okay.
It could standardize it more.
Yeah, so standardize it more. That means we can use those model in any place, any vendors, and that's our dream. Like
Yeah,
any,
that
yeah.
is a dream, of course. But yeah.
So one more, in addition to that, one more question is like, what is your experience when you approaching, like the almost all the participants are coming from the background of computer science or biomedical engineering. So this community is complete, mostly they want the data. So
Yeah.
I think they have the problem to how to approach, how we can approach, like the computer scientists, how we can approach the hospitals, how we can approach the radiologist, and what are the means, based on your experience, how they respond, the radiologist or the clinicians, and can you expand a little bit that experience also?
Yeah, there I agree. I think it's the same everywhere in India, in Germany, wherever you go. Radiologists are busy everywhere, and it's really hard to reach them. But so far, I have seen that if you have some great idea or something, you have to show them that how it can be helpful in their clinical practice or anything, because they are not interested in AI, they are not interested in anything. They just want to know if any of your technique, how it will help them in their clinical analysis, clinical diagnosis, or in treatment or anything. So you have to make sure that your idea should be somehow helpful to them. And also, I have noticed that if you want the data, then going to a clinic or a hospital is difficult. And if you want data just for your research, obviously to train your model or anything, then maybe you can also focus on research institutes, because getting a data at a research institute is comparatively easier than getting a data at the clinic or a hospital. And yeah, I mean, I do see a huge difference in that. And also, what was the
Yeah, some questions in the chat box.
okay. I opened the chat box, but
Okay, I will read.
sorry, yeah.
One participant is asking why lung-related applications primarily approached how AI can particularly applied for diagnosis and treatment of diabetes.
Why lung-related applications primarily approached? How AI can particularly applied for diagnosis and treatment of diabetes. Similarly, like with diabetes, I don't know any of the medical imaging technique, that how a medical imaging technique helps in diabetes, but obviously there are some blood, other biomarkers. You do not acquire them with the help of imaging, but there are other blood biomarkers that you can get with the help of your blood test or something, and you have a whole data set related to the blood information, glucose level information, and everything, and that can be used inside an AI model as a feature set or to train your model. So it's a similar way, just your parameters or biomarkers are different. How is quantitative? I hope I answered your question, but how is quantitative imaging analysis different from traditional qualitative interpretation and in CT and MRI? So as I showed in my, okay, I think that's where I started my talk, because, okay, so for example, when you look at a qualitative CT MRI, a radiologist only has to look at the image. By looking at the image, he tells, that's how it used to happen traditionally. By looking at the image, radiologist says that the tissue looks denser, tissue looks, if I have any of the image here, maybe. It will be very, yeah, for example, if you just look at the CT image, so here a radiologist, by looking at it, he has to tell, okay, this tissue looks dark, this tissue looks bright. They compare it with the normal tissue, normal CT image, and based on that, they say that there is a lesion, there is a tumor, or there is anything else. And it will vary from radiologist to radiologist and their experience also. So, but if you look at the quantitative imaging, you have a quantitative parameter, a quantitative information that you extract from your region of interest, and that parameter will help you identify that, okay, for example, in a simple terms, if you have a value 25 for a certain parameter, a threshold value, and if the value that you measure is higher than 25, it is a tumor. And if it is lower than 25, it is a normal tissue. So that's how the quantitative imaging will make it easier and less and more objective and less subjective. It won't vary from radiologist to radiologist.
Yeah, one more question, I think. Which reconstruction algorithm is mostly used for CT scan?
For CT scan, mostly used, it is iterative reconstruction algorithm. That is the best so far that we have used, because it also helps us to reduce some radiation dose as well.
One curious question, like because you already worked in both the domain, like both modalities, like MRI and CT.
Yeah.
So can you tell me, or you how can I say this? Which modality is comfortable for you? That I use that word comfortable for you in like for post processing and data acquisition and all things. Can you compare both CT and MRI, because you already explored all these things?
They both have their different applications, first of all, I would like to say. So we cannot just say that, okay, that this is better or that is better. And if I know that MRI is better, then we can completely eradicate CT. That's what I used to think when I started working in CT. But then I got to know that no, there are certain diseases or certain applications that only CT can fulfill, or CT fulfills better than MRI. Now coming to your question, that which I found easier comparatively, obviously CT was easier, because there it was comparatively easy, the pre-processing task or model fitting or mathematical modelings and everything, because I have worked on mathematical modeling of both CT and MRI by now, and I know in CT it was comparatively easier than MRI. In MRI, it's a lot more parameters also comes into picture, and that's why now I'm more inclined to MRI, because I want to do more.
Yeah, because I'm totally working in the MRI. So
Okay.
yeah, and CT means because you are comfortable in the sense, I use the word comfortable in the sense like the number of slices and the complexity of the images, and what parameter you like
No,
you
the
get
number
what?
of slices and everything is same. Your number of slices is same. Your parameter curves look similar. You also have maximum slope model here. You also have similar K-trans, CBVs,
Okay.
like blood flow, blood volume, similar parameters. But the mathematical modeling is comparatively easier. And while you don't have to take care of all those parameters like T1, T2, this, that. Here you don't have to take care of all these parameters. So that makes it anyway
Okay.
easier.
Okay.
You only have a dynamic CT image and
Yeah, understood. Okay. And acquisition time also, right? I guess.
acquisition time, yes. Acquisition time is also less. And it's like, for example, in CT, I know that I have put a phantom inside and I can do the scanning myself. For MRI, I know to do the scanning, I have to be more careful. I have to have a technician with me. For CT, I don't need a technician with me.
Okay, understood.
Mhm.
So some other questions?
There is this feedback.
What are the different methods to convert normal image to quantitative image?
Okay. I think what I understood is you want to know that the normal image that we acquire from the scanner and to get the quantitative data out of it, because we cannot convert a normal image to a quantitative image. There's nothing like that.
Yeah, I
So
also noticed like is there any quantitative image or quantitative analysis? I think they are meaning the meaning of that is quantitative
yes,
analysis or something like that.
maybe they can confirm, but I'll move to that one
Yeah.
slide where I want to what 1 minute, I don't know, something happened. Okay. You can, okay, nobody answered that what they actually meant, but I will just answer it based on what I understood. So if you look at these images, the image from D to G shows the quantitative images. So those are the quantitative maps that you obtain, but they are obtained after quantitative analysis, and that quantitative analysis is done with the help of some models, some mathematical models in the perfusion imaging. But if there are others, for example, diffusion quantitative imaging or anything, there are simple equations or something that you can put on these MR acquired images, and that can give you a quantitative image. But if you are asking that you have a normal image from a MRI and you can convert it to quantitative, that is not possible. You have to acquire a quantitative image. Either it is a diffusion, either it can be perfusion or anything. I don't know if I understood their question correctly or.
Yeah, I think that's the answer. And so, any other questions? No. I guess you are still you are acquiring the images without any technicians, and what is the experience with or during your data acquisitions? What are the challenges you faced? And also, in addition to that, one more question is like the participants also need from where we get the public data set for suppose they are planning to do some research in the CT or MRI, because they are all mostly the computer scientist per people. So they want to know from where we get a like a research data sets.
I think so. To get the data set, first of all, I think you might also know that we can get some freely available data online like Brax or things like that. So there are so much data available already online if you want to train your models. There is a group at Oxford. There's a group at there's a group at UPenn also that also provides this the free data, and they do have these contests. So if you want to train your model, you can easily access that data. I mean, I guess it's enough data is already available for training your model. And also For me, now I acquire my own data now. Previously, with I got the data already. My previous colleague was using, but now I'm acquiring my own data, and I do face problems with MRI because I have to have a technician with me first of all with MRI, and the problem is mostly with a high scanner. A, a high Tesla scanner. So now I'm working with both 3 Tesla and 7 Tesla scanner. And
Oh,
I have noticed that with the participants, they are comfortable with 3 Tesla scanner, but when we go to a higher field, they are more anxious or they have the dizziness and everything, and they sometimes abort the like day before yesterday, my participant had aborted the scan. So they do that at the high field scan more often because so those are the challenges also that is very basic that we face. And then it comes to acquisition. That is a completely different thing because of very loud noise, or we are going to high field. It has a lot more advantages with all my projects, I know, but we also see that it also leads to dizziness and more stuff to the patient. So that is also very uh, concerning to me nowadays because I have patients who already have some mental health disorders, and then so I have to take care of them a lot. But other than that, I guess now I'm yeah, acquisition wise, yes, every participant is different. For example, while acquiring a one sort of imaging, that is arterial spin labeling. So when we are doing ASL, we know there is something that we have to choose the vessel or something, and every participant is different. So if you decide that, okay, for this participant, I have to mark the voxel region here and it has to be perpendicular like this. For next participant, his artery looks like this. So you need to have a lot more experience, and at least you need to have someone to discuss to. So these challenges are like every day. We cannot just go click and go is not an option for us, at least not till now.
yeah, yeah. You are telling one great point. Like from 3 Tesla to 7 Tesla, there was 7 Tesla. What about the acquisition time? That is also a problem. Like for acquisition time is also, I guess it's more than the 3 Tesla, right? Eh,
No, no,
No.
no, no.
Okay,
Acquisition
okay.
time is not a problem. It's almost
Okay.
similar or sometimes.
And
Uh,
now
yeah.
I saw that like a 0.55 Tesla coming from the Siemens, and they implemented some AI algorithm for the better reconstruction. And I think in US they started the implementation of 0.55 Tesla for
Mhm.
reducing the scan time and all. I think maybe that
Yeah.
is that is overcoming these kind of
Yeah, that is.
small problems also.
Exactly. Yeah, as I said, recently we had a meeting with Siemens, and they also mentioned about these things, the thing that you're saying, that they are already incorporating that in their software. So hopefully these challenges will be overcome, or probably. And also they promised us that they will be incorporating these quantitative imaging analysis tools inside the scanner. Now
Yeah.
I do see that for CT. During my PhD, it was not there in CT. So I had to compute my own maps. Now, I don't know how good those maps are now, but in their Siemens software itself, you can have your
Mm.
perfusion maps there also, at least blood flow and blood volume, some of the maps.
Yeah, that's.
So that is really helpful, I think.
And one more question from the chat box. What are the different methods to convert normal image to quantity? Again, the same question. Convert normal image to quantitative image.
No, it's the old question only you're reading. I think the
Okay.
next question is, please give access to feedback
It's,
session
it's, it's,
6.
it's a
I think
different one.
it's for you.
It's
Yeah,
different one.
yeah, it's different. Yes.
Okay. So,
Yeah.
Sumaya, please.
Okay. Thank you, ma'am, for sharing your expertise.
Thank you so much.
Okay. Now, participants, can you please turn on your camera so that we can take a photograph?
I
Participants.
And stay at least for 30 seconds.
Okay.
Yeah, thank you. So, without any questions, we will stop now and we will resume the next presentation around 7:30. Thank you, Neha, for your wonderful speech and experience, especially for that metadata. That is also, I think it's a good point for the researchers who are working in this field. Like we should consider the metadata in addition to the simple images for training or model testing or etc. So that should be careful, and the AI have more challenges, and yeah, from vendor to vendor or scanner to scanner, it's not that much up to the mark. But everywhere, everyone say that like it's over. The problems like segmentation is over, and in
No.
imaging also some people are saying like everything is over 99% accuracy and 99% of prediction. So, but still challenges exist, and we will work for that, and hopefully in future we will get a good solutions, yeah, and overcome all these things. Anyway, thank you
Yes.
all on behalf of the KME Engineering College and ATAL FDP program committee members. I thank Neha for the
Thank you
wonderful
so much.
session, and have a nice day. Thank you.
Yes. Thank you so much. Thanks, Soumya. Thanks, Rafiq sir. Okay. Good day. Bye bye. Thank you for inviting
Bye.
me.
Thank you, ma'am.
For participants, we will start the second session around 7:30. Please fill the feedback form. It is available, the link is available in chat box. Either machine. Yeah, you are muted.
So am I audible?
Yes. How are you?
Fine, fine. Am I audible, Rafiq?
Yes, yes, yes. You are audible.
Okay.
So please share your slides, then we will check it's working or not.
Okay.
Yeah, it's visible.
It's visible
Yes.
and it's also moving.
Yeah. Yes. 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 It's moving.
So all content are there, na, in the screen or any clipping of the.
No, no. I think the screen is good and everything is visible.
Okay, and one thing more,
Yeah.
please. Is this video is running?
Which one? Yeah, you are sharing one slide and one. Yeah, back. Okay.
So one
Yeah.
video is like running. Is it visible?
Yes. 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 Yes.
Okay, okay, okay. Sure, sure. Okay, thank you.
So we are about to begin the second session of the fourth day of our FDP on advanced artificial intelligence and machine learning techniques for medical imaging applications. Sir, am I audible?
Yes.
So I think our resource person is here only.
Yeah, he's
Ma'am, it's audible.
Okay.
He's available.
Okay. It gives me great pleasure to introduce our esteemed resource person for this session, Dr. Dharmesh Singh. Dr. Dharmesh is currently working as a senior research and collaboration scientist for Asia region at United Imaging Healthcare. At United Imaging, he is engaged in advanced MRI research, clinical collaborations, and development of innovative imaging solutions with a focus on accelerating translation of AI-driven techniques into clinical practice with multiple renowned radiologists. He earned his PhD in medical imaging and machine learning from IIT Delhi, where his research centered on developing novel post-processing methodologies for quantitative medical imaging analysis, with a particular emphasis on multi-parametric MRI for cancer diagnostics and computer-aided diagnosis systems. Dr. Dharmesh Singh has co-authored around 15 full articles and over 40 conference papers, and he is a member of esteemed societies like ISMRM, AOCR, ECR, and RSNA, etc. We are truly honored to have such a distinguished professor with us today. With great respect and pleasure, let's welcome Dr. Dharmesh Singh to lead the second session of Day 4. Welcome, sir.
Thank you. Thank you for your warm introduction. So I am sharing my screen and let's start the lecture. Can anyone confirm that is my screen visible?
Yes, sir.
Yes.
It's visible.
Okay. Okay, then let's start. Good evening, everyone. So my name is Dharmesh and I'm currently working as MRI research and collaboration scientist at United Imaging Healthcare, Hong Kong branch. And I did my PhD from IIT Delhi. So as you know, like medical imaging is rapidly evolving field that plays very significant or pivotal role in modern healthcare by enabling early detection, accurate diagnosis, effective treatment, and with the exponential growth of data and advances in computational power like AI, artificial intelligence has emerged as a transformative force into the medical imaging. And that intersection of that AI in medical imaging, reshaping the way medical images are acquired, processed, or interpreted. So today we will explore a very exciting and evolving field like application of AI in prostate imaging. Specifically, I will be discussing all relevant applications in connection with my previous work and my recent work on this prostate cancer imaging. So we will begin with the brief background of prostate cancer and then move into the role of multi-parametric MRI in its assessment. And after that, we'll touch the challenges that radiologists face in prostate cancer evaluation, and this sets the stage for how AI is being applied in medical imaging. After that, we will then move step by step through the AI workflow for prostate cancer diagnosis, starting from prostate segmentation, classification of the tissues, lesion measurement, and automatic PIRATES assessment. And then I will then highlight how AI can support the detection of clinical significant cancer and how moving into like advanced quantitative approach like IBIM, DKI, and advanced diffusion weighted imaging and machine learning based diagnosis. We will also look at deep learning based tools which our company has developed and that our team has developed. And finally, I will discuss some important future directions, including multimodal data integration, and clinical adoption of these AI-based models. So start with prostate anatomy. So prostate is a small gland, which is basically a male reproductive system. If you imagine its shape, it's look like an inverted pyramidal shape. Base is broader, but at the top, and it tapers downward. So this is the prostate, and besides the bladder and up part of the urethra, and uh, which is that's why prostate diseases often affect urination and sometimes bowel habits as well. And now or anatomically, the prostate is divided into three distinct zones: central zones, transition zone, and the peripheral zone. The central zone, which is this makes up to 20 to 25% prostate volume, and transition zone, which is smallest zone, and which is make up to 5% of the volume. And what very important, because most of the uh, prostate cancer occurs in peripheral zone. This is very, very important, and this is the largest zone of the prostate, accounting for 80 to 85% of the prostate. And importantly, this is also reason where most prostate cancer originate. That's why prostate gland segmentation from here and prostate zonal segmentation is very important. And so when we interpret prostate MRI, so we pay very close attention to the peripheral zone because that's the most common site for clinical significant prostate tumor. According to Globocon 2022 data, so prostate cancer is the most common cancer in men and ranks fourth overall among all the cancer globally, as per the World Cancer Research. And also in that year, so around there were approximately 1.47 million new cases found. And looking at the trend in the past 2 decades, age standardized incident rates have increased in many countries, while age standardized mortality rates have mostly decreased or stabilized, which reflect earlier detection and better treatment. So now screening, like a lot of research going on screening tools. So now it has been seen that mostly age-based standardized mortality rates has been decreased due to early screening and better detection. So let's now transition to the cornerstone diagnostic currently used in clinical practice. These are the conventional diagnostic method, which is invasive in nature. Basically, that has prostate-specific antigen testing, digital rectal examination, and transrectal ultrasound guided biopsy. So PSA testing is basically a simple blood test which is measuring PSA level, it is called a protein type of things. And a simple blood test with measuring PSA level and elevated PSA is basically indicate the cancer. But also benign condition like benign prostate hyperplasia, the enlargement of the prostate or prostatitis, if there any infection in the prostate, it is also elevated the PSA. So it is very difficult to distinguish between these kind of things, like which is non-cancerous versus cancerous things. And other thing is DRE. DRE is digital rectal examination. A clinician physically examine the prostate and via the rectum to check any irregularities such as lumps and any other things are there. And other is TRUS biopsy. So if PSA or DRE raise suspicion, then TRUS is used to image the prostate and guide the biopsy needle to sample the tissues, typically via 10 to 12 core taken from the peripheral zone. But these are the conventional method, but these are have some limitations. Like PSA has been a standard line test, but it's far from the perfect. So setting a threshold at 4 nanogram per ml may look simple, but in reality, many aggressive cancers occur even at lower PSAs. And on the other hand, benign condition can push PSA above 4. So resulting in a flood of lot of unnecessary biopsies, which is a major challenge in prostate cancer. Over treatment or over like over surgeries or over biopsies. And DRE has been used for decades, but in the reality, it misses most of the cancers because they are non-palpable, and it's also highly subjective in nature. Two different clinicians may have different findings for trust for DRE. So it has low sensitivity, and trust-guided biopsies is still considered the gold standard, but it's come with a long list of drawbacks, like because it samples randomly and it can miss aggressive tumors, yet at the same time it may detect small insignificant one and leading to the over treatment. So on the top of the list, patients are exposed to a lot of procedural risk, including infection that sometimes required hospitalization. These are the limitation of current conventional diagnostic methods. And so there are different modalities. If we talk about like ultrasound, CT, PET, MRI. So ultrasound is good for guiding the biopsy needles, but by itself, it cannot characterize the lesion well because it's had low soft tissue contrast and low SNR and CNR as per to MRI. So that's why cancers are often missed in ultrasound. And CT scans simply does not give us the soft tissue contrast we need inside the prostate. So it's only reserved for staging when disease is advanced, like metastasis. So it will come after that. Like after MRI, we will do PET CT for the metastasis purpose. And PET imaging is powerful for advanced disease, but not suited for the early detection because it is very costly and it's not. And so this is why we now move to MRI. So or MRI, or you call multi-parametric MRI. So multi-parametric MRI is a combination of different sequences like T2 weighted imaging, diffusion weighted imaging, or perfusion weighted imaging. So it's called multi-parametric MRI. So multi-parametric MRI is the only modality that combine high resolution anatomy with functional imaging to truly improve detection and characterization. So the development of MPMRI has truly transformed prostate cancer diagnosis. So when we compare the MPMRI based guided biopsies with the conventional biopsies, then detection of rate of clinical significant improved by 91%, like 91% increase as per the comparison to 76%, and it's also reduced the detection of clinically insignificant cancer by 44% to like 83% to 44%. This means MPMRI not only find the right cancers but also helps to avoid overdiagnosis, okay, which is a major problem in this prostate cancer diagnosis. And to make like multi-parametric MRI reporting consistent, because reporting is also a challenging issue. We will discuss later this issue. So the prostate imaging reporting and data system, which is a guideline that was established in 2012 by American College of Radiology and European Society of Urogenital Radiology with the help of Admetech Foundation. So the latest version is released in 2019, which is Pirates version 2.1, and it's basically the scoring is a Likert scale values. Likert scale means 5 to 1 to 5 point scoring, which is based on some criteria like hyperintensity, hypointensity, lesion maximum diameter, lesion volume cutoff threshold is there. Suppose if lesion diameter is greater than 1.5 centimeter, so it will count as score 5. If less than 1.5 centimeter, it is count as score 4. So it's like these things, and this is a quantitative parameters. And so as per the Pirates 2.1, the dominant sequence for peripheral zone is diffusion weighted imaging and apparent diffusion coefficient. And for the transition zone, T2 weighted is dominant. So some studies also suggest that biparametric MRI. So biparametric MRI is very current topic in this prostate cancer. We will only acquire a diffusion weighted imaging and T2 weighted imaging, no more sequence. So it will also show, so some literature shows that the biparametric MRI, not multi-parametric things. So biparametric MRI may be sufficient for prostate cancer diagnosis. So two large metastasis, which will shows that how well pirates performs. So Wu et al. Conducted a study, like a metastatic study, which include around 21 studies with nearly 3,900 patients, and they found pool sensitivity of pirates is 0.89 and specificity of 0.73, which is good. And one more study is done by Zhang et al. And analyzed around 13 trials with over 2,000 patients, and it showed both sensitivity and specificity is around 0.85. So pirates is a standardized reporting system for prostate imaging. So T2 weighted imaging we will discuss first. T2 weighted and will come up with the AI things. So T2 weighted imaging is basically a basic pulse sequencing magnetic resonance imaging that represent differences in the T2 relaxation time of various tissues. So high water content tissues appears in bright in T2. So PZ often appears high single intensity for healthy tissue. This is a healthy tissue, which is this is the prostate, and it is considered as the healthy because it is hyper intensity is there. If normality in the brightness means mild hyper intense on a T2, indicates a disease process like cancer. Mild hyper intense, it causes like some cancer is there. And on T2 weighted imaging, prostate cancer on transition zone typically appears as homogeneous hypointense content against a background of the high signal intensity with ill-defined margins. And due to high fat content, the transition zone is exclusive site for benign prostate hyperplasia. So which is mimic as the cancer, but it is not cancer. There are some enlargement of the prostate, which is mimic like a prostate cancer thing. And diffusion weighted imaging, other sequences, diffusion weighted imaging, which is very crucial for prostate imaging, is a MR imaging that generate based on the difference in browning motion of the water between the tissue. And this movement is called diffusion. And in cancer, water diffusion is more restricted. So diffusion means movement. If movement is restricted, then means small the signal attenuation and high signal intensity. So prostate cancer appears bright in the diffusion weighted imaging, and the rate of the water diffusion is called ADC. ADC is apparent diffusion coefficient. Is measure the magnitude of diffusion within the tissue, and it is calculated by a mono exponential model. And B is a gradient factor, and S1 is the signal intensity. B1 and B0 is a gradient factor, and so this is a basically so ADC is derived from diffusion weighted imaging. If a lesion is shown as bright in diffusion weighted imaging, and it is shown as dark as in the ADC. So it is the as per the Pirates rules. So challenges. So we all agree that multiparametric MRI or biparametric MRI combined with the Pirate scoring system has dramatically improved prostate cancer detection over the last decade. But there are some still challenges. So first, there is inter-reader variability. If two radiologists looking at the same scan may not always agree about the conclusion. So especially when it's come to the subtle or small lesions. These inconsistency can impact diagnosis and ultimately patient management. Okay, so first is inter-reader variability, and second is we face limitation in screening. Many patients still undergo unnecessary biopsies because of overdiagnosis or interdeterminate findings, leading to overtreatment of the cancer that may never become clinically significant. Okay, so third, we may look the Pirates version 2.0 scores, then it is suffer from some heterogeneity, like for example image quality issues between the centers and between different MRIs, like 1.5 Tesla or 3 Tesla makes a difference, and protocol standardization is not always followed in clinical practice. And perhaps most importantly, the interpretation is highly subjective in nature. So Coyote's version 2 is highly subjective. So AI in this case becomes more objective and provided decision making as a tool for the decision, which make the very easy for the decisions for the radiologist. And finally, the biggest clinical challenge remains predicting which patient truly need treatment, or which patient doesn't need the treatment, and which patient can be safely monitored, like active surveillance, which is called, and which patient can be actively, like, safely monitored. And this decision is not always straightforward. And it's here that errors or overtreatment often occur. This is exactly the gap where artificial intelligence comes in. So AI has the potential to improve accuracy, reproducibility, efficiency, while also supporting radiologists in making more confident, evidence-based decisions. So this is the application of AI in medical imaging. So now that we have discussed the challenges of conventional like prostate MRI discussion, and let's move on to the how AI is transforming medical imaging. First, we have computer-aided diagnostic tools, which is one of the application of AI in medical imaging. So this system helps radiologists by highlighting suspicious lesions, reducing oversight and improving diagnostic confidence. Second, predictive risk assessment, which is AI models can analyze imaging features along with clinical data to predict which patients are more likely to have aggressive disease and like supporting better treatment decisions. And third one is workflow optimization. So AI can automate tedious tasks like pre-processing, reporting, and even triaging scans, which saves valuable radiologist time and improve efficiency. And fourth one is lesion detection and classification. Perhaps the most well-known application AI tool can detect small prostate lesions, classify them as a benign, malignant, or intermediate lesions, and even provide Biret score suggestions. Next is quantitative biomarkers. So AI extracts some quantitative features like texture, radiomics features from MRI, and sometimes which is invisible to the human eye. So this provides objective biomarker for tumor aggressiveness, response to the therapy, or progression risk. And other one is application is in image segmentation. AI-driven segmentation can automatically outline the prostate gland, and it's also segment the prostate zones, and uh, this is crucial for quantifying the tumor burden and guiding biopsies. Okay, so then after that we have image fusion and multimodal integration, which is AI can integrate data from MPMRI with PET-CT, genomics data, and other clinical data to provide a comprehensive diagnostic picture with supporting the personalized medicine. And finally, image reconstruction, which is a hot topic like AI-based reconstruction. So AI-assisted reconstruction technique like deep learning-based denoising or accelerated acquisition like compressed sensing. So, which improve the MRI quality, which improve the SNR, CNR, and other quantitative parameters, and which also reduce the scan time, which is very comparable and good as per comparison to the conventional scans. So, which is particularly important in prostate imaging also. So, overall, AI is just a diagnostic aid. It's shaping the entire imaging workflow from acquisition to interpretation and clinical decision making. So AI-assisted compressed sensing, as we have, as I talk about. So this is basically enabling the faster scan and more patient-friendly examination. It's all is already integrated into commercial systems. From United Imaging side, it's called AI-assisted compressed sensing (ACS). From GE Healthcare side, it is called AI Recondial, and from Siemens side, it's called Deep Resolve. From Philips side, it's called compressed sense. So it's already like a lot of work is going on in this area, image reconstruction and enhancement. So yeah, so this slide summarizes the current overall clinical workflow for prostate cancer diagnosis, how AI can be integrated to support and improve it. So at the top, you can see in the red box, we see the conventional clinical workflow. This is a conventional method. First, a patient first come for the screening, then usually through a physician, And then if there are any concern, then the case moves on to the radiologist who interpret MRI or ultrasound as per the requirement. Then the urologist perform the biopsy, and then pathologist confirm the diagnosis through histopathology. This is the standard pathway that we follow today. But as we know, there are some limitations. It's time consuming, highly dependent on the human interpretation. So there is a room of variability at each step. So now if we look at the green section, so now we look the green section, then where this is where AI fits in. So AI can support prostate cancer diagnosis directly by analyzing MRI and ultrasound and histopathological imaging, highlighting suspicious areas. So, for example, in the MRI or ultrasound shown here, it's AI highlight the potential lesions and even distinguish between aggressive and in yellow and the indolent cancer, which is like green part. Sometimes that's critical for treatment decisions. And beyond diagnosis, AI also help with supporting tasks, like for instance, you can say automatic prostate segmentation and registration between MRI and ultrasound, and it's also registration between MRI and histopathological data. So it's good for the ground truth pathology. So in essence, this figure is telling us while the traditional pathway in physician driven and somewhat subjective, so AI makes his very objective in nature. So it doesn't replace the clinicians, but it augments them, and every step of the workflow, it saves the time, and it acts as an intelligent assistant for the radiologist. Okay, so based on the AI and his and their scoring, they can predict the final judgment as per AI and their manual assessment. So this is the diagram which is summarize the computer-aided diagnosis model. So we are now discussing the AI-based application in the prostate cancer. The first one is the computer-aided detection and diagnosis system. So AI model prostate cancer can be broadly divided into two aspects. First is the classification, and second one is the detection, like lesion detection. So let's walk through the pipeline. So first, we start with the prostate MRI itself, which is include multiple sequences like T2 weighted, diffusion weighted, or dynamic contrast. So these sequences capture different aspects of tissue properties and are critical to detecting the cancer as per Pirates rules. Next comes to prostate segmentation and registration. Here, AI automatically identify the prostate boundaries and also align images from different MRI sequences. So this ensures that the lesion is accurately localized. And then we move to lesion marking and feature extraction. So AI system identify potential suspicion reason. So this is the part of lesion detection task, and it then extract the quantitative features, something like shape features, intensity feature, texture features, which is called a radiomics feature. So texture features is a great area to do research, and which help characterize those reasons. Okay, from there we enter the feature selection and the classification. So out of many extracted features, AI select the most informative ones and classify the lesion based on the features. So for example, distinguish aggressive from the indolent cancer. So this is the lesion classification task, and result from compared to the gold standard one lesion score from the pathology. So in parallel, AI can also perform 2D and 3D lesion quantification, like measuring the lesion size, shape, volume over the multiple slices. So AI can also measure the lesion diameter, lesion volumes, and all. Finally, all of this information is integrated into the automated pirate scoring, and the AI system basically assigns pirate scores categories consistently and objectively, followed by validation. And yeah, so to be summarized, so to summarize, the upper part of the workflow focus on classification, while the early and middle stages represent that this is the detection and this is the uh, classification. Together, these tasks bring us closer to a fully automated, reliable, and reproducible system for prostate cancer diagnosis using MRI. So now let's talk about one of the fundamental steps, which is the application of AI in prostate cancer, which is segmentation. So segmentation is basically, you can say, segmentation of prostate gland, and Jones is very crucial because it's crucial because the 70 to 75 or 80% prostate cancer originate from peripheral zone, and other cancer is originate from transition zone. So if we segment out these zones, then it will be very helpful. So these basically this shows actually this work has been carried out using the data set from AIMS Delhi, and one of the open data set. So we collected around 59 data set from AIMS Delhi, and then we developed an atlases using 3D MRI, and also tested this algorithm into the open source independently evaluated data set like Queen prostate repeatability data set. So now let's walk through the workflow step by step. We begin prostate diffusion weighted imaging as an input, and then we apply a Canvas active contour method for the prostate gland segmentation. Once the gland is segmented, we extracted the region of interest. So this is a prostate gland. And after that, we extract the region of interest. Okay, so after that, we perform the 3D affine co-registration across subjects using AI, so machine learning based AI algorithm we use for the 3D affine co-registration. So image registration is very crucial for this methodology. And from this, we generate a statistical atlas. And after that, these provides the probabilistic atlas based on these probability map for transition zone and the peripheral zone. And then we create a mask for TZ and PZ at the chosen threshold probability, which is 0.5. And test data is then registered to this atlas. And after that, zonal segmentation is applied for the new patient, and then it is the segmented result. But you can see there is some part is missing. So we have developed a method. It is called partial volume correction based on intensity, probability, and the distance, in which we can easily actually estimate the pixels between transition zone and the peripheral zone. So it is a foundational because any error in gland and zonal segmentation propagate downstream into the lesion detection and feature extraction. So this is the methodology which we have adopted during our work and published in one of the journal. And yeah, so these are the result is basically of our segmentation result. So the first table shows the performance of segmentation on 3D MRI data set, and these are the for the open source data set. You can see that moderate performance, particularly in the peripheral zone, and when we apply the partial volume correction algorithm, and it increases significantly for the both data set. And yeah, so box plot also shows that it's very clear that the red plot show the segmentation performance without PV correction and after PV correction. So the green plots with PV correction, and across dice the card coefficient and the accuracy, so there is a statistically significant improvement. So yeah, so this means this algorithm is not only improving averages scores but also reducing variability. So in summary, the partial volume correction step significantly enhances that segmentation performance, especially in transition zone, which is more difficult area, and this step strengthens the foundation for downstream AI tasks like lesion detection and pirate scoring. So this is the further result based on 1.55 Tesla. This is also vendor neutral algorithm. So, and sorry, for the MRI, you can use in 3T and 1.55 Tesla. So it is shows the robustness of this method, and it is also like same as the previous result. So now these probability like AI based probability atlases that you have seen here. So not just for our study, we have been made publicly available on GitHub. So what it means, anyone interested in exploring this area can directly access and use them. These atlases are basically designed for prostate gland and zonal segmentation. And the best part is they can be applied using straightforward any good registration method. So the registration, so the researcher don't need to reinvent the wheel, and then like they can start from these ready to use atlases and build upon them for their own studies. So other application is basically the prostate cancer classification or PIRATES classification or PIRATES score classification. So we begin with the like prostate MRI acquisition. You can see diffusion weighted imaging, ADC is there, and highly sensitive to the tissue changes in the prostate cancer. Next, we perform the prostate gland segmentation. And after that, we moved our ROI selection. So identify the suspicious region within the segmented prostate. So once ROI is defined, then we extracted the texture features from different models like first order statistics, which is called histogram based features, gray level co-occurrence matrix, which gives us many of feature like 19 to 20 features from GLCM. We have gray level run length matrix, we have loss texture energy measures, statistical feature matrix, and Gabor wavelet based features. So these are the texture models which we acquire around 120 or 130 texture features from there. So, but from there, not all features are equally useful. So that's where feature selection comes in. Using method like random forest or correlation-based methods, so we identify the most discriminative features. So now comes in the most key step like classification. So we train our model and such as like linear SVM, Gaussian SPM, and k nearest neighbor like classifiers we have used and to differentiate between cancerous and non-cancerous. More responsibly, we also like classify the PIRATES grade. And the result even validated using tenfold cross validation and ensuring the like robustness and generalizability. Finally, the system output is classify the PIRATES grade on low grade, intermediate grade, and the high grade. And high grade further classify into PIRATES 4 and PIRATES 5. So the classification is very essential and very crucial for decision making step in this workflow. So this is a one type of classification method. You can choose your own develop texture features, feature selection, and there are a lot of features and like lot of feature selection method. So as per your requirement, you can choose that classification methods and all. Okay, then these are the results. So when we looked at the classification for prostate cancer into the three class classification like high, low, and intermediate, it shows around accuracy is around 93.8 percent. And when we sub classify into PIRATES grade 4 and 5, then it shows around 91% using random forest feature selection and Gaussian support vector machine. Okay, so and the proposed overall, when we extended the analysis to cover the whole spectrum of the PIRATES, like PIRATES 2, PIRATES 3, PIRATES 4, and PIRATES 5, like 4 class classification, 2 to 5, the proposed framework delivered a diagnostic accuracy of around 84.9 and AUROC is around 0.98. So which just shows a good indicating a like excellent discriminatory ability of our model and summarize our like our approach is not only accurate in the broad grading, but also very reliable in the finer clinically challenging sub-classification. Okay, and so after that, we will go like segmentation has been done, AI-based segmentation. So AI-based classification has been done. Now we move to AI-based tumor quantification and automated PIRATES scoring. So first, we have the prostate MRI. We have done prostate gland and zonal segmentation. We have done lesion marking. So now we have so lesion measurement. So lesion measurement is basically traditionally radiologists do in a 2D manual measurement using any tool like image or DICOM viewer or any other tool provided by the vendor or company. And AI can perform 2D ellipse fitting or 2D ellipsoid fitting to measure the tumor size and volume more accurately. 3D measurement are particularly important for vital lesion characterization and treatment planning. And yeah, so after that, based on these lesion size, signal intensity, so AI assigned the automated pirate score. So this reduces the inter-observer variability and speeds up the reporting. So this is the whole like workflow for the automated pirate scoring also. So this is where we compare different methods. On one side, radiologist traditional measurement, which is typically a manual 2D measurement of lesion dimensions. And in the middle, you can see like in this, you can see the 2D ellipse fitting, which is semi-automated approach, but the system fits an ellipse around the lesion boundary of the MRI slices, which gives us more consistent measurements compared to manual marking. So once the lesion is marked, the next step is Pirates version 2 assessment. So we have tumor volume uh, based on that, and we have tumor diameter. So we build a model based on that, based on these two features for the automated pirate scoring. And based on the lesion size, imaging features, the system can assign the pirate score. So here the role of AI provide an automated pirate scoring system, which makes the reporting more standardized. So these are the result for our pirates assessment as compared to radiologist assessment. So here we see comparison of accuracies of different measurement and scoring methods. So the green portion of each bar represent the correct classification, while the red portion shows the errors. So on the left, radiologist based manual assessment, like our AI based manual, this assessment achieved around 93.75% accuracy for the score 2, and 90% accuracy for the score 3, 83 for the score 5, and around 74 or 75 for the score 5. Okay, so this shows that which is important here, like accuracy numbers, but in fact, even the automated pirate scoring so strong agreement with the radiology assessment, which is agreement is around 0.94 and which is a clinically significant. And this demonstrates that the potential of AI to assist radiologists to reduce subjectivity in the pirate scoring. So it can help as a decision support tool, as a supporting tool, which can provide the which region is score 2, which region is score 3, which region is score 4, and which region is score 5. Okay, so now let us look how the ROC analysis work. This is the region ROC curves. This shows the discriminated performance of our method. So LDA means linear discriminant analysis model achieved 0.94 for the pirate assessment of the all score classification, like all scores, like grade 2, grade 4, grade 3, and the grade 5. And when we compare the low grade, like grade 2 and grade 3 versus high versus like grade 4 and grade 5, then AOC will increase to 0.95. So these high means AUC value, especially close to 1, show that automated pirate scoring basically reliably distinguishes between benign and malignant lesion. When we compared automated pirate assessment with radiologist scoring, we found a strong correlation. Okay, so this work has been published in Frontiers in Oncology. And now let me summarize the result of our automated pirate scoring. So as you can see here the performance of the automated systems is very close to the radiologist, and which means the algorithm can reliably reproduce expert level scoring, the ROC analysis, further to confirm the high discriminative analysis, and also most importantly, the automated pirate scoring, which has the very strong positive correlation with the like 0.94. So this validates the reliability of our AI-based tumor quantification. And so overall, these results highlight the AI has strong potential to serve as clinical decision support tool. So now other application of AI is to detection of clinical significant tool. And this is a very hot topic nowadays to detect the clinical significant tool and develop our own a different scoring system other than pirates, which can include quantitative features with clinical parameters. So this is focusing on the development of multi-parametric quantitative and clinical scoring system. So so we have worked in this area also, and we begin with the lesion measurement step. We have used automated illustrating or AI based approach for lesion volume and lesion maximum diameter. So we have got pirate scores. We club them, like we club lesion measurement based like lesion volume and lesion diameter with pirate scores. So it's called comprehensive prostate cancer scoring for detection of clinically significant prostate cancer. So for checking for the accuracy and performance of this system, we classify the non-cancerous and cancerous lesion based on these methods, and further classify cancerous lesion into low grade and high grade. This system basically generate a pirate score. Yeah, so this system this integrate lesion measurement and pirates features and machine learning based classification. So the goal is here to move beyond the pirates alone and provide a more complete and objective prediction of the prostate cancer status. So this is very, very innovative and current trends in the prostate cancer nowadays. So you can like combine different clinical parameters with quantitative parameters. Yeah, so this is the complete pipeline for comprehensive prostate cancer scoring system, which is a complete pipeline. Like okay, so integrate pirate scoring and AI based pirate assessment and the illustrating. So this is the our approach which we have adopted in this case, like based on Likert scale. So which integrate pirate score and lesion volume and the lesion score. So lesion score is a basically histopathological parameters for the histopathological grade for the prostate cancer. Here we assign pirate. Suppose if score 5 is there, so we assign Likert scale 3 and score, and after that score 2 assign intermediate grade and score 1 assign low grade. And based on the literature, we found that lesion volume cutoff is 0.5 centimeter cube. So if lesion is greater than 0.5, it means clinically significant tumor. So we assign 2, and less than 0.5, we assign 1. So here only also like lesion score, lesion grade 1, 2 means intermediate, and 4 means high grade, and 5 means very high. So based on that, what we have do, actually this provides so comprehensive prostate cancer, we calculated the Likert score 1 and 2. Okay, so where we can relate CPSS to we then relate CPSS to Gleason score in 2 ways. First is we classify into the cancerous versus non-cancerous. If these scores is greater than 4, like if this is 4 and 5, it means it is Gleason score 6, and if 3 and less, it's called like Gleason score less than 6. Like it is non-cancerous. And if we classify the low grade and clinically significant prostate cancer, so it is basically classified different like Gleason, if Gleason score greater than 7 and if Gleason score 6. So overall, this system provides a structured way to combine imaging-based pirate scoring and volumetric analysis and histological correlation. So it allows us to stratify patient into non-cancerous, low-grade cancer, and the clinically significant prostate cancer, which is critically for guiding treatment decisions. Yeah. So these are the results based on this. So this shows good accuracy for the clinical significant. So now we will move to the advanced quantitative parameters, like application of AI in based on advanced quantitative parameters. So we are looking here AI in prostate cancer assessment, specifically advanced quantitative parameters using IVIM. IVIM is intravoxel incoherent motion diffusion weighted imaging, which is a advanced diffusion weighted imaging. So here we extract the image features like D. D is a true diffusion coefficient. D star is a pseudo diffusion. F is a perfusion fraction, and ADC is a apparent diffusion coefficient. So here we evaluate whether IVI and DWI quantitative parameter could add diagnostic value in prostate cancer or not. Because as per the literature and the current trend, prostate cancer research is open. So anyone who is interested, anyone can do the research and report their own values, which will be considered for the pirates reporting or standardized reporting, like standardized guidelines for the future updates, like pirates. If in 2026 there will be pirates 2.2, suppose, so these features will be included if anyone can report their values based on advanced techniques. So secondly, the use of these parameters, the second objective is to classify of the prostate tissue into healthy, BPH. BPH means benign prostate hyperplasia, and the malignant group, and also compare the IVIM parameter with pirate scores. So this study basically we studies around 60% suspected from the prostate cancer, and with the help of our clinical collaborator in our company, and we have used 1.55 Tesla machine from UMR 580 United Imaging Healthcare machine, and from the IVIM we extracted these features, and we see, like, we combine these features and then we see how it's reliable for the accuracy. So these are our AI-based post-processing tool for IVIM detection. It shows the raw image, it shows the D star, D star, F, and that ADC maps. You can mark the ROIs automatically, and then you can extract the features. So based on that, we build a model, and these images, like, basically these are the diffusion weighted imaging, DMAP. So DMAP means lower values in malignant tissues reflecting the high cellularity, and D star map, which is the pseudo diffusion coefficient, more variable linked to the perfusion. So F map is a perfusion fraction, which reduce the perfusion seen in the cancerous regions, and ADC, which is derived from the mono extension model from the diffusion imaging, which classify like malignant lesions show lower ADC compared to healthy and BPH. So this is the table which shows the all the values, and it shows that if we using this single value, then accuracy is less. When we combine all the parameters, then accuracy is increased by 83, like up to 83%, and AUC 0.88, and we have used here Gaussian SBM. So these are the ROC curves. So conclusion of this study is IBM DW parameter provide distinct tissue characteristics, and while individual parameters show moderate accuracy. And when we compare the machine learning, so when we combine with machine learning, it significantly improve prostate cancer classifications, achieve more like 83%, and AUC is 0.88. So this demonstrates the strong potential of AI-based multiparametric analysis or IVIM-based analysis as a complement to pirates in clinical practice. Okay, so now we have discussed a lot in the previous slides. We have discussed conventional and machine learning based studies, and also presented the result of our own study based on IVM and DWI. So I would like to take this step further and give you a practical demonstration of the deep learning based AI tool that our company, means United Imaging Intelligence, which is a dedicated company for deep learning, has been developed. This tool developed by United Imaging Intelligence, and this integrate the workflow we just discussed, like prostate segmentation, lesion marking, quantitative parameter extraction, and to automate pirate scoring, and it allows radiologists to quickly obtain consistent and reproducible measurement. So while also provided a lot of while also providing AI-based tumor quantification. So the aim is supporting to the radiologist to reduce the subjectivity and improving the diagnostic coefficient and saving the reporting time, because in India reporting time is very the burden of the radiologist is very crucial topic. So how we save radiologist time, and the crowd is more, like patient is more, so it is a like a technology which using by lot of radiology in the world. And so a hierarchical multitask CNN framework with weekly supervised learning that integrates course, mid and fine structures. And if we talk about the this network is organized into four main parts, like backbone, course level, mid level, fine level, and the losses in the end, like training. So backbone network shared the feature extracted from the multiparametric MRI. Okay, so these are the basically using by the shared with the from the multiparametric MRI. We have course level approach branch, which is learns from radiologist inputs, like radiologist zone level interpretation. And we have mid level branch, which learns from the biopsy. We have fine level branch, which learns from the voxel level segmentation from whole mount pathology. Means the input is learned from the as per the radiologist input, biopsy input, and segmentation inputs. So these are the branches of this main branches. And then in the backbone, ROI volumes from T2 weighted, diffusion weighted, and ADC maps are there. So these are the inputs. And the features depth grows progressively to 32 convolution to 1024 channels. And output is rich feature maps used by all three branches, course, mid, and fine. Course level branch, so this is a radiologist info. So this takes the backbone features, and few convolution layers are there, plus global average pooling is there. Fully connected layer 512 and 3, like one per prostate zone for peripheral zone, transit zone, and the central zone. Finally, softmax probability gives the probability of prostate cancer in each zone. The softmax is using for the probability distribution. Okay, so mid-level branch is biopsy info. This is a provide the biopsy info. It's deeper backbone features, convolution up to 3 into 3 into 3, 1024 channels, global average pooling, and fully connected layer correspond to 12 core biopsy regions. And softmax output is around probability of prostate cancer in biopsy region. So this is basically is the input, like training. For the training, we gives a lot of inputs from all the level, like radiologist, biopsy, and different levels. Okay, so fine level branches, pathology segmentation. This is a unit like decoder structure, 3D convolution, and with the transposed convolution upsampling, and also using the 1 into 1 into 1 convolution with softmax to output. So purpose is produce voxel level prostate cancer segmentation aligned with whole amount annotation. So basically this is a deep learning network which we customizably designed for this task. And after that, we have training strategy losses. So multi-level cross entropy losses will be used in the course region, and one-sided level smoothing cross entropy used in the in the mid level. Dice loss for segmentation is used, and hierarchical optimization train course mid fine to balancing weak and strong supervision. Okay, so this is the tool developed by United Imaging Intelligence, and this is I am going to show you the live demo of deep learning based networks. How these tools working in a real time, actually in the centers, in the diagnostic centers. Okay, so now I am okay. So now I am closing this and showing you the live demo. Okay, so this is our tool. This is only for the demo purpose, but this tools is basically nowadays available as a commercially available. So this is the front end of our tool, in which all the cases are there. Okay, so we have around 50 plus tools for CT. We have CT tools like coronary, pulmonary nodules, lung nodules, pneumonia detection, and all. We have MR-based tools. We have MRI brain parcellation, like MR brain volume, morphometry. We have resting state fMRI, DTI, and all. And we have also prostate-based tools. So we can select here MRI prostate. These are the demo cases which we have used. Just click in this, and it is calculated. Like it is calculated within a second. It shows.
Hello, Dharmesh.
Yeah.
Hello, Dharmesh. Sorry to interrupt you.
Yeah.
I saw the slides only. So other participants, I don't know. So can you check one more time?
Okay. Sorry. Okay. 1 minute. Stop sharing. Again share. So now it's visible.
Yeah, it's coming. It's showing like yeah. It's visible.
It's visible. Okay. And just to go. Okay. So I'm talking about. We have a lot of tools. And some of them are FDA cleared, and some of them are CE cleared. And these are the patient. You can choose the application. We have CT based tools, we have PET based tools, we have MRI based tools, we have memo based tools. So we have a lot of tools in every domain: liver, lungs, brains, knees, everywhere. And we can choose MRI prostate here, and just click this patient, and it is calculated within a second. Okay. So can anyone confirm now its screen is showing or not? It's visible. Rafiq?
Yeah, the screen is visible.
What
It's
is
like
showing?
P3 patient number P231.
Okay. Now it's not showing now that one. Okay. It means I have to share again. Stop sharing. Then sharing. Okay, got it. So now it will be shared. It is showing.
Yeah. It's images.
Yeah, so this is the tools, like deep learning based tool which we have discussed earlier. So this is a tool for and this is a tool which is lot of radiologist and is using our tool. And just click on the patient which is acquired, and then it will within a second it is it will be segmented the prostate gland lesion segmentation, and it shows the largest diameter, and it is also tell where is the location is, like right base transition zone posterior. It shows the diameter, volume, and based on these features, it's assigned the Pirate score. Pirate score is 5, means high grade tumor is there. Okay, so there are a lot of information is there, like so there is tumor 1. If there is multiple tumor, then it is shows the multiple tumor also. If there is any bone metastasis in the prostate, it shows the bone metastasis parameters. Okay, so yeah, so and it shows all the key slices, and you can also check the risk level, high sensitivity level, and all. And also you can uh, segment out the transition zone here. So the best part of this tool is you can, if radiologist want, then radiologist manually customize this lesion detection. If they find that this is not correct, here they can add our own contour and delete this. Okay, and there is add diameter, like lot of things are there. And best thing is this is also providing the image findings, which is very, very helpful for the reporting purpose. Like prostate measuring is there, and you can also 1 minute. And you can also here from here you can generate the report, which can be very, very useful. Just click this and it will generate the whole report with all the demographic information of subject. It will all the clinical parameter is there, and it shows the pirates and like all the you can see all the important key slices from here, and it is very, very important. Yeah. So this is the deep learning based tool which we have developed, and this is commercially available. And yeah, so this is the basically real time example of these tools, and lot of customers or lot of radiologists use these tools from our company. Yeah. So now move to again this one.
Yeah, this is very exciting, Dharmesh. So one small question related to this: is this tool purchased any hospitals? Obviously,
Yeah.
purchased, but
Yeah. A lot of like in China, in US, and in India also. Though they
okay.
purchase around 10 to 12 hospital purchase this. Actually,
Okay.
this is comes with a whole package actually.
Oh.
So I will show you. So this is one. This is so you can see here. 1 minute. You can see a lot of tools are there. CT based tools. Okay. And MRI brain basically tools. If we go for MRI brain parcellation, like MRI brain region segmentation, suppose, so it will calculated MRI volumes and MRI brain segmentation within a second. Suppose, wait.
So that means your company United Imaging is it's like running successfully for implementing all or
Yeah. We have all
deploy-
cleared like FDA and CE approved
for
these tools.
deploying these devices. So these two.
Yes. So we have validated these tools in around 1,000 and 10,000 cases from all over the world, like multi-vendor, multi-centric, multi-countries.
Yeah,
Okay,
that's
so
an
uh,
exciting.
yeah. So I'm sharing 1 minute. You can see. Uh, this is very exciting, like brain region segmentation. So this is our brain region segmentation and brain region volume. So actually, if we go for FSL and all, it will like it is very, very time consuming and very, very. So it will see it will segment the brain regions in 109 region within a second, and it shows all the uh, if there is any abnormalities there, so they can show here. And yeah, so if and it is very, very like follow-ups cases are there, atrophy is there. And if you want to calculate all the volumes Excel file will be generated. This is very, very useful, and we are doing a lot of research based on that. 1 minute, and it can be used in different diseases like MS, multiple sclerosis, Alzheimer's, Parkinson diseases, and these are the brain regions. Shows the volumes: hippocampal region, parahippocampal, temporal lobes. All the volumes are there, and reason are there. If you want to select only hippocampal region, then it is also like shows only hippocampal. This is a very, very important, like very, very good tool, and also FDA cleared. So
Yes,
this
so
is
I
the
think these are very useful for clinician or radiologist.
yeah. So it is very, very useful, and report is very, very good. Like you can generate the report, and in the report you can find lot of volumes, like lot of information which will be very, very helpful for the radiologist. So at this like lot of tools are there in our package. Like you can buy purchase as a package for this.
Okay, so that means this is you provided to anyone like anyone requested or something like you installed or you added these techniques with your machines installed institutions
Yeah.
or any
Okay,
institution
okay. So
that you
these
can?
all, so two point is this. These all tools are basically vendor neutral. So lot of requests coming from the also different vendors. So we installed these tools in our actually our centered also, and also the other than our vendor like Siemens, GE or Philips. So you can use anywhere these two.
Okay, very exciting, Dharmesh.
Yeah. So okay, so we are now here. So these are the tools, and we discussed this AI-based tools recently, and now we move to. Okay, so this is the video of that one. So the future direction is what? Like we have done a lot of things like machine learning, deep learning. So what is the future things? So as we look ahead, prostate cancer is very open field. So anyone working in this area can contribute and report their results. So the next big step is integration of multi-model data. Like if we include more and more data like genomics data, proteomics data, clinical data, patient outcomes. So it will be give more and more better result. Okay. So this integrated approach will provide a more comprehensive and personalized assessment of prostate cancer. And equally important is validation and clinically adoption. Okay. So you need to train your model in lot of different like countries, different vendors, different areas. So it will be increase your a clinical adoption more. And for AI tools to make it impact, they must be rigorously validated in large multi-centric trials and gain of confidence of clinicians, routine use in practice. And overall, the future of AI holds tremendous potential in this domain, not only to transform clinical workflows and improve patient outcomes. Because we have discussed a lot of, we got feedback from a lot of radiologists from the world, like Europe, Latin America, Middle East America, Southeast Asia. So we got they called as intelligent assistant. So it will not replace any radiologist, but it help as a decision supporting tool, or it is called intelligent assistant. Okay. So these are the differences. And I would like to sincerely acknowledge my PhD team, Dr. Amit Mandiratta and Dr. Anup Singh, and my clinical collaborator from which I presented this the work in this seminar with Dr. Virendra Kumar and Dr. Chandan J. Das from AIMS Delhi, and also would like to thank my current colleagues from my current institution, like from United Imaging Healthcare. So I'm working in Central Research Institute. So it is called institution. So yeah, uh, so thank you to all my collaborators, and thank you. This is the whole picture of AI imaging. So if you have any question, then feel free to ask me, or if you want any collaboration, if you need any help related to medical imaging AI domain, so please feel free to email me. This is my email ID. Okay. Yeah. Thank you, Rafi, and thank you.
Dharmesh, yeah, thank you for your wonderful presentation. And some questions are they pasted in the chat box.
Okay.
Answer those questions.
Okay, so if we are doing research, then what important parameter we need to consider in our work to explain our model performance well when compared with other authors? Okay, so as I said, you can include lot of parameters. If you talk about prostate cancer, so there are PSA is a very good important factor, like PSA density, clinical parameter is there, and no one include this important parameter in his research. So you can include quantitative parameters like texture weight features, radiomics features. There are a lot of models. like shape-based features, and with clinical parameters like lesion volume, diameter, PSA density, prostate gland volume, pirate score, and also if you have any like histopathological data like lesion score, or if you have if your data have pet pet scores and pet ways or any other clinical parameters, so you can include and you can check which basically which parameter is useful for the classification purpose. So you can, and which increase the model performance. So it will be deal by feature selection technique. So yeah, so I can suggest, so if you include more and more clinical parameters with the quantitative parameters, so it will be good. And a lot of research going on in this area. And radiomics with feature extraction useful for prostate MRI. Yeah. So a lot of research are going on. Radiomics features is very, very important. And actually radiomics features is providing the localization of the lesion, which will guide to the radiologist where is the exact location of the tumor is. So in the aims, if I can say, so one of the our uh, uh, known radiologist is using that tool and using that tool for the screening purpose, and it is very, very helpful. So give me your email ID. Yeah. So I have shared my email ID, and I will also share with Rafiq. You can. Okay.
Yeah.
So which MRI sequence produces the most informative features for training, deep learning, modeling? Okay. So nowadays, if you talk about three MRI sequences, very, very useful. T2 weighted imaging for the anatomical, diffusion weighted imaging, and the dynamic sequence. But nowadays, biparametric MRI, as I can say, like T2 weighted and the diffusion weighted, both work as per as the performance of multiparametric MRI. So you can start with diffusion and the T2 weighted, because uh, uh, in the perfusion you need to give the contrast and all. So and the role of perfusion weighted imaging is very, very less in the, so 50% hospital doesn't acquire this perfusion weighted imaging. So 50% is only depend upon the T2 weighted and the diffusion weighted. So you can use only this one. And can radiomics feature can really help in telling apart aggressive? Yeah. This is, yeah. So radiomics features are very, very helpful. So as per you exact like extract lot features, then it will be good. And radiomics is a different domain, and you can extract lot features. So what are the trade-off parameters we have to get a better model? Okay, so trade-off parameters are basically trade-off parameters. We have to get a better model. Okay, so trade-off parameter is basically the input provided by the radiologist, like manual marking of the prostate lesion and all. And you need to provide the lesion volume. Like first you need to train the model. So the important is lesion maximum diameter, lesion volume, and pirate scores. These three things are the best parameters for the best diagnosis. Okay, thank you.
So thank you for yeah. If any other questions, please. No, I think
Yeah, if any other wants to like ask me any question, then I can. So this is my email ID, singh.dharmesh@unitedimaging.com. So you can mail me if you want to collaborate, and if you want to stuck somewhere, and if you want to initiate some studies based on that. So we can help in this matter.
yeah, I'm very excited because of your tools. You demonstrated something like it's for every parts of the body. You said like for
Yeah.
muscular, for brain, breast, everywhere. So
Yes.
that I'm like super excited. Like in India also, some hospitals you mentioned that some hospitals, but so that news is also like yeah, it's very good. And we like our the computer scientist or biomedical engineers, they are this is one inspiration, like global
Yeah.
leader United Imaging, they
Yes.
started these kind of tools and they have approved, these tools are approved by the FDA. So that's a
Yeah.
great news. And if any other, what are the trade, what is the role of electronics in this study? Oh.
Okay, so electronics, so there are signal processing, image processing is there. So these are the part of electronics and communication engineering or the electronics. Yeah. So if you have that knowledge of, so you can apply like image means matrix, or you can how to deal with the matrix and how to extract the features. So like they were.
I will share the email ID to that participants. Okay, all the participants. I will share it within WhatsApp group. No
Okay,
issue.
okay, okay. And if you want to collaborate, and if anyone want to work
Yeah.
in United Imaging as an intern or any other, if you want to explore our technology, then do call me and please call me.
Okay. Sumaya, please.
Okay. Thank you so much, sir, for sharing
Thank
your
you.
expertise on AI-based diagnosis and detection systems for prostate cancer. Your
Mhm.
talk truly valuable, and we appreciate the way you showcase the applications of AI in improving diagnosis accuracy and efficiency. So, on behalf of KMEA Engineering College and Department of CSE, we extend our heartfelt thanks to you. Thank you,
Thank
sir.
you, thank you, thank you so much, thank you so much, thank you so much, Rafiq, and thank you so much all the listeners, and thank you so much for inviting
Yeah.
me.
Yeah. Thank you, Dharmesh. Have a
Thank you,
nice.
thank you.
Thank you all participants. We will see you tomorrow. The session will start around 6 p.m. tomorrow. So everyone will join. And thank you all. Have a good night.